Thanks, John, and thank you for the invite and for braving the very quiet tubes, which is great. So when I got the call to do simple echo in 20 minutes, I was a little bit terrified to work out how I'm going to structure that. And add to the fact that, of course, with echocardiography, virtually everybody in the room has quite a deep exposure to echocardiography already, and therefore it's quite difficult to calibrate exactly what is required for a course such as this. So what I've done is I've tried to narrow it down to a few questions, which is the left ventricle okay? Is the right ventricle okay? Is the pulmonary artery pressure elevated? How bad is the mitral regurgitation? How bad is the aortic stenosis? And what's the mass? If you wanted to know about aortic regurgitation, apologies. Please feel free to email me, but you can't cover everything. So, starting with the left ventricle, and hopefully the movies are running. Some of them are running a bit slow today, but they'll get there in the end, or not. I think one of the things that we do is spend a lot of time talking about left ventricular function, but we don't spend enough time looking at left ventricles and actually looking at the images that we see with echo. And of course, there's a huge amount of information you can gain from just looking at the two-dimensional image, whichever of the various views you want to look at, whether you have wall thinning, which is causing severe LV dysfunction, which already tells you have ischemia. It already tells you pretty much what the regionality of some of that ischemia. You can almost predict what the angiogram looks like. Whether you have morphological features such as asymmetric septal hypertrophy and systolic anterior motion, which are not pathognomonic, but certainly highly suggestive of cardiomyopathies. Whether you have concentric thickening, and we see a lot of LVH, and whether that's disproportionate, and whether that thickening could represent, for instance, an infiltrative diseases as a case of amyloid, or again in the acute setting, and I think this gets missed a lot. This is a sad case of a young man that sadly died, but before he died, he presented with a short illness, and the left ventricle is clearly thick. He has no reason for it to be thick, but because it's not an infarct pattern, kind of doesn't get noted, and of course this is a classical acute myocarditis with inflammation and edema of the myocardium, all available from the two-dimensional data set. When we look at measuring left ventricular function, then obviously we are focused on dimensions and volumes, and we have a variety of ways to look at that. M-mode, although unfashionable because it doesn't necessarily measure exactly what you're looking to in terms of the geometry, actually offers you a very high frame rate and a very high spatial resolution. So in some cases, particularly measuring the thickness of walls, if you're happily aligned, M-mode is excellent, and of course the evidence for that goes back for more than 50 years. The mode of choice is, of course, Simpson's biplane here, looking at the volumes in systole and diastole. But, of course, we have other means. We can enhance things, for instance, with contrast, and now we can use three-dimensional echo, which we'll talk about more in the next talk. But the really important point that I would make is that all of these methods give you different numbers. So we're very numerical, and we're very driven by saying, if we've got an end diastolic volume of this or an end systolic volume of that or an ejection fraction of that, we know where we are. But of course, we must make sure that we understand which actual method has got us there. And of course, the least reliable of the lot being visual assessments. These numbers relate specifically to the ESC guidelines for end diastolic dimensions, and end diastolic volumes and ejection fractions. This is another problem because, of course, a variety of societies have a variety of guidelines, and the BSc has just come up with a new set of guidelines last week. So these relate to the ones that relate to the ESC board exam, but it remains a matter of opinion. What we do know about ejection fraction that is really bad about telling us whether someone has heart failure, this is from Euroheart survey, and you can see in both men and women the distribution of ejection fractions in patients presenting with heart failure is pretty much normally distributed, and consequently the ejection fraction in isolation is an exceptionally poor guide to whether somebody has heart failure. Good guide to what therapy may be of benefit, but not whether they have heart failure. And we all know that you can have a very normal looking ejection fraction of around 55%, or you can have an ejection fraction of 75% in amyloid because the cavity is small And consequently, we often see these patients labelled as having normal systolic function when we all know they don't. But because the ejection fraction is normal, people use the terms synonymously. What about diastolic function? Diastology is obviously something of a dark art and is more susceptible than anything to recurrent position papers, views, a variety of techniques, thousands of techniques in order to define it. The fact that it moves with filling, the fact that it moves with age, all make it extremely complicated. The most straightforward way of looking at it, just looking at the transmitral Doppler trace, of course, runs the problem that that changes, particularly with filling and age. E to A ratio, the traditional means, doesn't really help that much. The E prime, the systolic velocity of the septal lateral wall, is quite useful because it does go down with reduced diastolic function, but it also goes down with age. So we're faced with the kind of philosophical decision is what's disease and what's just normal. And the E over E prime does give a good guide to left ventricular filling pressures in certain circumstances. Some circumstances it is less good at doing that. One example is hypertrophic cardiomyopathy, which is disappointing because that's when it would be extremely useful. This is the algorithm from the ESC guidance, or the ACVI guidance, which basically is much better than the previous because it's slightly less rigid and it accepts a range of parameters, including E over E prime, septal E velocity, lateral E velocity, tricuspid velocity, recognizing a lot of these people have low-grade pulmonary hypertension, and LA volume, and actually says, let's totalize it up. It's a much more intuitive approach and says, well, if you've got less than half of those are positive, you probably don't have diastolic dysfunction. If you've got more, then you probably do. So I think that that is a much better way forward. If your ejection fraction is reduced, there is a more complex algorithm which I put up there on the slide, but I don't know about anybody else, but I don't use this because in the majority of people with systolic dysfunction and reduced ejection fraction, diastolic dysfunction comes alongside, and therefore going through a very, very advanced algorithm to define whether a disease which you already know to be there is maybe not useful. There are other parameters, and of course the thing that we lose in ejection fraction and in volumetric approach often is this concept of longitudinal function, which we can measure in a variety of ways. The new kid and probably the easiest on the block is left ventricular strain, demonstrated here, which I'll talk about later in more detail. But roughly, if you have a left ventricular strain of minus 20%, or longitudinal function of minus 20% in global longitudinal strain, your ventricle's probably okay. And the other, of course, is the left atrial volume. Now, you can argue around whether 34 mils per meter squared or 38 mils per liter squared represents a point, but clearly if you have a very big left atrium, you probably have a very bad myocardium, whatever the ejection fraction. RV assessment, a similar slightly dark art, and again, this is a nice diagram taken from three-dimensional echo because it shows how totally dependent on imaging plane measurement of the right ventricle is. So although we like to measure things, we have to be clear on what we're measuring, and we should be looking at this right ventricular optimized view, which comes a little bit higher than a standard four-chamber view and allows a full disclosure of the right ventricle. But patients differ, and sometimes it's very difficult to achieve that. So we have to take any of these measures with some degree of caution. But we do have some numbers. So most recently, the basal RV dimension of 41 millimeters comes out as the upper limit of normal. When we're looking at function, the way that it's most usually done, of course, is by looking at the long axis function of the right ventricle, either with TAPSE or with a right ventricular systolic velocity, 17 and 9.5 respectively being the numbers. Right ventricular wall thickness should not exceed a centimetre. If it does, it's very suggestive of pathology, particularly infiltration. What about diagnosing raised pulmonary artery systolic pressure? Well, again, we've probably moved beyond just measuring the TR velocity and adding 5 or 10 or 15 or 20, depending on what we thought the IVC looked like, and particularly in those difficult mid-ranges where we're thinking, well, obviously if your maximum velocity is 5 meters per second and your pulmonary pressure comes out at 80, that's like not an issue. But when you do have TR velocities in the 2.8 to 3.5 region, looking at other parameters, particularly looking at the size of the right ventricle, the circularity of the right ventricle becomes very important. So I'm going to take a clinical problem. I'm doing this with a show of hands, and I hope people will disagree about this, because certainly when I tried it before, they did so. I'm looking at a 28-year-old male with no family history of heart disease, normal ECG, cycles 80 kilometres a week, screening echo done because people have more screening echoes done than ever before, shows an interventricular septum of 1.1 centimetre, a diastolic dimension of 5.4, an ejection fraction of 50%, GLS of -22, RV basal dimension of 4.3 and a TAPSE of 2.8. So a variety of parameters that come out of what we had before. If they're not immediately to hand, I'll tell you that the septum's a little bit up, the diastolic dimension is just about the upper limit of normal, the ejection fraction's a little bit reduced, the GLS is normal, the RV basal diameter is a little bit enlarged, and the TAPSE is normal. So can we have a show of hands for a normal heart? Likely to have DCM with mild LV impairment? Needs an MRI? That is interesting. Displays signs of athletic heart? Needs a CPEX? One exercise physiologist in the room, fantastic. It's interesting, isn't it? Because this is a very, very, very frequent patient. Yeah? This is not rare on any line. And actually, if you look at all those functional parameters, the ones about volume are just a tiny bit elevated. And the ones about function are very good. So I would have voted for a normal heart, but I think the answers do lie between the athletic heart phenotype and a normal heart. But I think that this is in line with a normal heart. So pericardial effusion, obviously start with mild, we get to moderate, and then we get to severe with a big pericardial effusion and a swinging left ventricle. One of the things that I think causes more trouble than it probably should is around constriction, and I suppose by implication tamponade, which really obeys three specific rules in physiology, but also in echo, which is when you breathe in, the flow goes up through the right side, when you breathe out, it goes up through the left side, and the heart can't expand. Therefore, the pressure has to stay the same throughout the whole, all four chambers, leading to ventricular interdependence. And looking at echo Doppler, obviously you can see increased flow through the right side with inspiration, increased flow through the left side with expiration, and this sign which causes a huge amount of excitement, which is the septal bounce. And I see a lot of people talking about septal bounces, but this is a septal bounce, and obviously these patients are not that easy to image, so I apologize that it's a bit of a grainy image. But the key parameter here, which you can see, and you can also see on the M mode there, is that it's respiratory dependent. So you can't see a septal bounce on every heartbeat. You see that reported a lot, septal bounce. You have to be able to look at free breathing, and you have to be able to see the septum bounce on inspiration, which is what you see there. So the key thing, septal bounce, you have to be able to see a number of cycles and watch the septum go across. And that's because the flow has gone down on the left and consequently up on the right, and the pressure gradient moves the septum towards the left. The other sign which is increasingly useful, particularly in constrictive pericarditis, is reversal of the normal pattern of tissue Doppler between the septal and the lateral wall. The lateral wall normally is much freer than the septum, but in constriction it's constrained, and therefore it goes down the lateral wall, and the septum is freer, so you'd see a reversal. And that's particularly true looking at the E prime velocity, which is the easiest to look at that. Okay, sorry, that septal bounce doesn't go. Okay, so classical clinical problems. 65-year-old patient feels unwell and breathless. LA closure device 24 hours ago. No anticoagulation. Pulse 94. Blood pressure 100. No echo signs of tamponade. Fairly straightforward clinical scenario, really. Should you repeat the echo in an hour and look for... This is the echo, by the way. Should you repeat the echo in an hour and look for a change? Septic screen. Drain the effusion. CT to check mediastinum or reassure. So... show of hands for repeat the echo in an hour and look for a change. Yep. Septic screen. Drain the effusion. CT to check the mediastinum. Reassure. Okay. I mean, I would have gone drain the effusion, and in fact, in this case, drain the effusion was the right answer, recognizing that this is acutely after a intervention. And with soft signs of, clinical signs of compromise, the fact that there is any sort of effusion, and we shouldn't be looking for signs of pericardial tamponade on echo, we should be just treating the clinical situation in front of us. But I also think repeat an echo in an hour and check there's been no change, given that it is a small effusion, is very rational. So, moving on to valves, obviously echo does valves very nicely, and I'm looking at the mitral valve because it is probably the one in which there's more ambiguity, and of course we divide this now quite clearly into primary valve disease here with a P2 prolapse seen on transthoracic echo and an eccentric jet of mitral regurgitation, and secondary MR where the valve leaflets are normal. And the reason to put that, you'll see why I'll put this up in a moment, but you can see that actually the ventricle looks normal here, but there is elements of annular dilatation, there's elements of restriction, and when you look here at the parasternal long axis view, you can see that the posterior leaflet is quite restricted. The MR not always straightforward, and we'll come back to that. So normal leaflets, abnormal leaflets. And over the years, for many years, the data has become increasingly clear that the more mitral regurgitation you have, the worse is your prognosis. And if you quantify that using the PISA method, then that will give you a much clearer view on what your prognostic implications are. And following PISA measurements in patients with mitral regurgitation is incredibly helpful in telling us what to do, and probably becomes an indication for action as you hit the severe range. But unfortunately, PISA is not always achievable in everybody, and so really having an understanding of the jet velocity shape is as equally important in quantification, and recognizing that there is this flow acceleration zone here seen in a three-dimensional echo, and if this is big, then it's going to be more severe. That the vena contracta, which may be round if you've got a round lesion such as a prolapse, but it may be very long and cover the whole coaptation line, is very important, and of course matters to do with the jet in the left atrium, which are much less important than what's happening actually at the coaptation line. This is the grading of mitral regurgitation from the EACVI and the ASE, showing the division between mild, moderate and severe, and picking up qualitative, semi-quantitative, such as the vena contracta width, pulmonary vein flow and so forth, and then the quantitative measures of effective regurgitant orifice area and regurgitant volume. Regurgitant volume of greater than 60 being the definition of severe. In primary mitral regurgitation. In secondary mitral regurgitation, there is more of a problem because we know that the prognosis gets worse from a much lesser degree of mitral regurgitation, usually a regurgitant volume around 30 mils. Now, whether this makes it a target for therapy is obviously, in light of the COAP study and the French study, a matter of great debate, but nonetheless, 30 mils in secondary mitral regurgitation is significant. And I just wanted to again highlight, this is the same case, but now you see the transesophageal echo, which demonstrates this wall-hugging jet of mitral regurgitation, the Coandra effect, which is a basic fluid dynamic effect with any high-velocity jet where it hugs the wall and loses energy. And therefore, if you see that, that means it's more severe than if it wasn't hugging the wall. Doesn't mean it's severe, but it means it's more severe than your quantification would suggest. So just rehearsing slightly the echocardiographic indications for primary MR, here P2 prolapse. If you have an ejection fraction which is impaired, less than 60%, then your ventricle is failing and you need an operation. If you have an end systolic dimension of greater than 45 millimeters, if you're European, then your ventricle is failing and you need an operation. In America, if it's less than 40, you need an operation, and I think most people would be much more comfortable with the American number, despite the fact that the 45 is in the European guidelines. And critically, the likelihood of success. If you've got a good surgeon and a high likelihood of success, then you're going to be more aggressive. Elevated PA pressure to some extent, and left atrium dilated to some extent as well. So finally, quickly looking at aortic stenosis, obviously a careful look at the etiology is something that you can do very nicely with echo. You know, you have got this very good two-dimensional imaging, and you can see the difference between true tricuspid degenerative and, for instance, bicuspid disease, or slightly odder pathologies such as radiation with the very clear thickening of the fibrosa and the mitral valve involved, or even odder pathologies. This is amyloid of the aortic valve. Am I right for time? Am I running a bit tight on? Okay, quickly. Obviously, aortic stenosis, the conventional assessment is based around the maximum velocity and the peak and mean gradients diagnosed using the Bernoulli equation of 4V max squared, remembering that that only applies if your subaortic flow is relatively normal. Once the subaortic flow goes up, you have to use the long form, and that will give you a different number. These are the numbers which represent severity, so a peak velocity of greater than 4 being severe, a mean gradient of greater than 40, and an AVA less than 1. Most of us in the room will be aware that those numbers don't add up, so an AVA of 1 is much more likely to represent a mean gradient of around 35 millimeters of mercury, and a peak velocity of 4 is likely to be an AVA of about 0.8. So there is inconsistency even within there. So we look firstly at the velocity-based measures, but then we correct for flow, recognizing that as the flow goes down or up, the velocities across the valve will change. So flow correction comes in two forms, either in the form of the continuity equation aortic valve area, or possibly the more useful dimensionless index, which gets rid of one of the leading causes of error, which is the measurement of the LVOT. The velocity index being simply 1 divided, the flow on either side of the valve divided by each other. Here are the numbers. So a valve area of less than 1, clearly being severe aortic stenosis, but also a velocity index of less than 0.25. So you're left after that assessment with a conventional assessment of an aortic valve, which is it's not severe, the flow is good, and the gradient is less than 40. The aortic valve area is greater than 1. Or you have what we all used to understand by aortic stenosis. The flow is good, the gradient's high, and the aortic valve is small. That's easy. Or you get possibly severe aortic stenosis with a low gradient, which is where I think all of the debate sits, where the flow is reduced, and the gradient is low, and the valve area is low. And you still don't know whether that is A, a measurement area, 2, low gradient aortic stenosis with a reduced ejection fraction, or paradoxical low flow gradient where the ejection fraction is normal. I don't want to go into that because that's a long talk. But what I do want to go into is when the echo doesn't add up, because I think that measurement error is one of the principal issues here. And the first of these is that your LVOT is wrongly measured. You can see that there are huge opportunities for error when measuring the AVA, depending on where you measure the LVOT. This is one of the major reasons, and when you measure the LVOT or you do it by some other imaging, CT or MR, you often get much more congruent values. Or maybe because you have stenosis underneath the valve, subaortic stenosis, a degree of hypertrophic cardiomyopathy. Just literally the gain settings can make a tremendous difference to what gradients you achieve. It's quite easy, potentially, to get very high gradients because you've polluted your signal with mitral regurgitation, because you've measured the LVOT at the wrong point, or this, saving the best to last, which is the principal reason why we get things wrong, is that we measure the aortic stenosis gradient from the apex with a standard probe, and we do not go around the chest looking for where the highest velocity is. And in up to 60% of people, the highest velocity will be not measured from the apex. So if you think, oh, this looks like bad aortic stenosis, and the gradient's low, the next thing to do is to look for the flow going the other way around because somebody's done a right parasternal. And this is one of the major reasons why we get this wrong. So finally, quick one on masses, when to worry, when not to worry. So don't worry on the right. On the right, you've got this one we see loads of, which is this mass at the back of the right atrium, and people are organising all sorts of tests and putting people on anticoagulation. And this is a crista terminalis. It happens that on this occasion, you can see it's lipomatous, and you do get, if you've got a lipomatous septum, it often get a lipomatous crista terminalis. And here, again, you've got a prominent eustachian membrane. There's nothing dividing the atrium. It's not core triatrium. It's just a persistent. So things, particularly in the right atrium, tend to be reassuring. Then we've got the things that we need to worry about. So here, a rather small fibroelastoma, of which the risk of embolism is about 13% over 5 years. There's a lot of debate, and people talk, oh, should we put anticoagulation, should we leave it, should we? But actually, the risk of embolism is quite high with a fibroelastoma. And importantly, the size of the fibroelastoma does not predict the likelihood of its embolization. There is no relationship between size and embolic risk. And of course, a myxoma, something that we all know about, and I put the 3D up there just for show. And then finally, the things that we need to panic about, which is, this is the IVC, and we can see the right atrium and the stuff crawling up into the right atrium. But this is, I suppose, a more cardiovascular, which is where you can see a mass within the heart, but it's crossing an imaging plane, and you can see clearly the little pericardial effusion. That finding of a mass plus a pericardial effusion or something to suggest it's crossed an imaging plane, very suspicious of a primary cardiac malignancy, such as an angiosarcoma or lymphoma. So finally, in conclusion, and I cannot do basic echocardiography in 20 minutes, but cardiac morphology plus chamber quantification plus flow generally equals diagnosis plus or minus prognosis. We measure everything, but we should look more. So I think we do need to beware the cardiologist with the ruler who has 1,000 measurements but doesn't synthesize that into a diagnosis. And 90% of clinical questions can be answered by echo first, but fortunately, with the rest of the faculty, the rest of the 10% will be resolved. Thank you very much.